Good morning, everyone. Welcome to Cardiology Grand Rounds. I'm so pleased to introduce Dr. Silvia Priori, who will be speaking to us about gene therapy for the heart, challenges and opportunities. Dr. Priori completed medical school at the University of Milan, where she also received, in addition to the MD, a PhD in cardiac pathophysiology. She's currently a professor of cardiology as well as molecular medicine at the University of Pavia in Italy. Dr. Priori is well recognized in the field of inherited arrhythmia disorders. Her research spans from bench work looking at mechanisms of disease to clinical research with over 440 original publications. Dr. Priori was the first person to identify the ryanodine receptor mutation as an etiology of CPVT. She served as the president of the European Heart Rhythm Association as well as multiple other boards and editorial positions and has won countless awards for her work. Please join me in welcoming Dr. Priori for Grand Rounds.
Thank you very much, and good morning, everybody. So the title of this talk, Gene Therapy for the Heart, Challenges and Opportunity, is actually something that will be reporting what is an in-between topic. Part is a research project and part is a dream of myself and especially of my group. And my group will be acknowledged as we go on because without their help and their fantastic willingness to find solutions for our patient, we would not be where we are trying to move forward. These are my disclosures. And so let's see what is gene therapy. Gene therapy has been a dream for many investigators, and actually it started in a very negative way in the 90s, where attempts to develop gene therapy resulted in premature death for terrible immunological adverse reaction to adenoviruses that were the vectors used to deliver the nucleic acids that were supposed to be the therapeutic agents. So actually the key concept about gene therapy is that of modifying or interfering with the consequences of alteration that are present in the DNA, or modifying the expression of certain proteins that may result a curative or at least therapeutically effective in the pathophysiology of diseases that are not primary genetic diseases, and I will show some example of this. So in cancer and in genetic diseases is where a lot has been advanced in this field, and I think that today we are at a very interesting time that is called the renaissance of gene therapy, thanks to some advancement that we have made in the delivery of the nucleic acids that are used. And this renaissance can be summarized in the large number of trials of gene therapy that are going on. If you start following this literature, you will see that almost every week there are reports of new therapies that have been tested, especially in the fields, as you see here, of cancer diseases and monogenic diseases. And so I think that is from this field where we have more results, but definitely there is a long list of other conditions. And I would point to ocular diseases that are becoming really another new frontier, because the retina diseases can be treated in a very advantageous way because they represent a very small localized environment where you can reach the needed concentration for gene therapy to be effective. And the hematology field with the treatment, gene therapy treatment for hemophilia is one of the other fields that will have a major impact in a very short time because the trial is already pretty advanced. Neurological diseases also represents a frontier that is being aggressively developed at this time, with a couple of trials going on with very interesting preliminary results. And cardiology in all that, unfortunately, we are lagging very much behind for several reasons that are always the one that complicate research in the heart. It's not a very accessible organ. the cells are terminally differentiated, and of course you cannot get samples of cells to see what the infection is doing and how the gene therapy is working. So for all these three reasons, I think that in our field is more complicated to work and is more complicated to really make rapid advantages. So as I said, you know, the vectors are the most important challenge in the gene therapy, as they were the challenge at the beginning. So the adeno-associated viruses represent now the frontier, and other possible carrier of the DNA have been explored, but none of them, of all these other alternative, and especially polymers and liposomes that have been attempted, you know, seems to be good for a place like the heart in particular. So why the viruses and which viruses? So the introduction of the adeno-associated viruses has been something that has changed the game, mainly because these viruses are viruses to which we are very exposed, and this is on one side an advantage, on the other side a negative aspects. Negative aspects because being exposed to these viruses, 50% of the population has antibodies against this. So you're trying on one side to use them as therapy, and on the other side you have antibodies that will attenuate the effect, and this drives you to go with higher dosages with potential off-target effects. But the positive thing about the associated viruses is they do not elicit, at variance with the adenoviruses, this immune response that was the cause of the problems in the past. The major limitation of the adeno-associated viruses is that the amount of DNA that you can put in is limited to 6 Ks. So let's say you want to put the cDNA of a gene that is a big gene, let's say the ryanodine receptor, it would never fit in the capsid of the virus. Even if one thing that is done in these viruses is to remove their nucleic acids that control their replication. So basically, we use the virus as a biological syringe, taking advantage of the property of going inside the cells, reaching the nucleus, and injecting something. And that's something we want to be our therapy and not the DNA or RNA of the virus. So the easiest approach for gene therapy, easiest not because it's easy to do it and easy to be successful, but easy because it's a logical concept, is you think of a clinical condition you acquired or genetics, and then you know the pathophysiology and you say, in this disease, this protein is reduced as a consequence of the pathologic process or as the initiation of the process. And if we could repristinate an amount that is physiologic, we could be curative. Or you have a genetic mutation that causes a loss of function, so you have either less wild-type protein, or you really have a protein that is not able to assemble or to go where it should go because of the mutation. And then you use this strategy that is called gene replacement, because what you do before manipulating and putting things in your virus, you create what we call it a construct, where you have several aspects that make it work and be transcribed in the cells, like, for example, the promoter. And then your therapeutic cassette that can be the cDNA of the gene of interest for the protein that you want to replace. So, for example, in our case, wanted to fix the problem of the recessive CPVT, in which calsequestrin is the mutant gene. We know that there is a loss of function, so calsequestrin is dramatically reduced, and then you can think about putting calsequestrin here, and then putting all this construct in your adeno-associated virus, and then delivering it to the mouse model, in the future, hopefully to the patient, and hope that this DNA will be inserted in the nucleus, translated, transcribed, and become a real protein that is functioning, fixing the genetic defect. Obviously, all these steps should not be taken for granted. Sometimes you have a nice construct and is not working, is not infecting adequately the cells. So the concept might be straightforward, but the response of the cells not necessarily is straightforward. One beautiful aspect of the adeno-associated viruses is that the scientific community has done an enormous amount of work to try to identify viruses that were maybe not infecting humans, but infecting animals or plants or so, that showed a tropism for specific tissues. So all this work of studying different serotypes of adeno-associated viruses, meaning viruses with different protein in the capsid that characterize what is called the serotype, led to this classification of viruses that preferentially infect the liver, preferentially infect the muscles, preferentially infect the heart. And so you will see that most of the research in the heart is done using adeno-associated virus 9, adeno-associated virus 8, or 6. And this is because they tend to preferentially go to the heart rather than to lungs or testes, ovaries, brain, or other tissue where we don't really want to express these proteins. So we have done a sort of ABC in understanding of the gene therapy. And I want immediately to show where the best result or the best attempt has been done in the gene therapy for the heart. That is this trial called CUPID, and we have had a CUPID 1, CUPID 1A, CUPID 1B, and CUPID 2, and this is the CUPID 2 results. So I am saying something contradictory, pivotal contribution of CUPID 2, and then I'm also telling you that CUPID 2 was a negative trial. The idea behind the CUPID 2 was very ambitious, and what the authors wanted to do, this work that comes from Mount Sinai, Roger Ajar's group, they started from the evidence that in heart failure, there is a decrease in the SERCA protein, a protein that regulates the amount of calcium in the sarcoplasmic reticulum, uptakes the calcium from the cytosol to the sarcoplasmic reticulum. And he thought that correcting this lack of SERCA could be curative or therapeutically useful for heart failure patients. So they started infecting, they did a lot of preclinical, of course, in pigs models and so on, and then they got approved for a clinical trial. So the first 2 pilots were positive, and they reported an increase in the ejection fraction in the patients after the treatment. But unfortunately, the real trial, you know, when they really randomized the patient and so, did not show any benefit. However, we still consider this a very important contribution because obviously what is the contribution is not about the efficacy or not efficacy of the concept, but has been to set a level of safety for the gene therapy delivered to the heart. And this, of course, is a first step that is needed. So we are very happy that a trial has been done without reporting any signals of side effects and adverse event in the population, as this is the step that then will facilitate introduction of other gene therapies for the heart in the future. So now we can say that there has been more than 160 patients with the first 2 pilot trials and the bigger trials that has been done and was negative, with an AV1 circa 2.8. So now the AV1, by most investigators who are working for gene therapy in the heart, is considered an old virus, and most of the people would move either to the AV8 or AV9. But still, the idea is that we have a level of infection, and also they showed that it was advantageous to deliver this through the coronary arteries rather than injecting it IV. So that is another concept that we have learned from the CUPID 2. So obviously, our dream would be to cure or approximate cure of long QT syndrome, Brugada syndrome, CPVT, with replacing the function of the genes. And in CPVT or in any other of these conditions, we have either gain of function mutations, meaning mutations in which there is an increase in the function, and therefore there is too much sodium current, too much potassium current, with the expected consequences at the level of modification of the action potential. Or there are loss of function that goes the opposite way. gain and loss of function. So how conceptually you could approach these two conditions is pretty clear. For loss of function, you can do a gene replacement if the gene is small enough that can fit in the adeno-associated virus. And for the gain of function, you can use the RNA interference strategy and try to downregulate not all the protein, but specifically the proteins, the mutant protein. So create an RNA molecules that is specific only for the mutant protein that is present in the patient. Very difficult and challenging because, of course, in most of the mutation that we have in these conditions, the gain of function results from a change of a single amino acid. So having something that is highly selective for a protein that differs of only one amino acid is quite challenging. But this is the concept behind our idea of trying to develop a therapy for this condition. So first, the question was, can we use gene therapy to treat inherited arrhythmias? Is there a probability that this would work? And then the second question is from what we need to get started. So the first question has been very strong limiting factors, because for a couple of years we have tried to apply to different grant agencies, and we were invariably rejected with the statement that no way the gene therapy would work to treat arrhythmias, because the rationale behind a stable heart rhythm is that all the cells are electrophysiologically uniform, and therefore it would not work. Then the other concept is when you can test gene therapy. And obviously you can test it only when you have a good animal model with multiple readouts. And for readouts, you mean endpoints that you want to see normalized by your therapy. And unfortunately, in all these conditions, we don't have a lot of animal models, because eventually you can test them in cells, but eventually you need to go to an animal model. So for long QT syndrome, we don't have a good mouse model. We don't have, we have some rabbits, but they are not knock-in, they are transgenic. So it's not the same thing. You cannot test gene therapy there. We tried at NYU to make a pig with Brugada syndrome when we worked with Glenn Fishman on this project. And the pig with the sodium channel mutation pathogenic for Brugada in the patients did not develop Brugada, developed conduction disorder. So that was another obstacle. And so I think that in CPVT, we are very lucky because we have animal models that fit the need of being similar as a arrhythmic phenotype, but as many other features as well with what we think is the clinical condition. So we decided to go to treat this disease. So just a couple of words on CPVT. Is a disease that was considered an abnormal form, a strange form of long QT syndrome with normal or borderline QT, because the patients have exercise-related arrhythmias. The arrhythmias at variance with long QT are not torsade, but are this kind of bidirectional VT that can be stable for seconds and then suddenly in one beat degenerates into VF. This is one of our patients. And the outcome of these patients is pretty severe. So in an untreated condition, these patients become, symptomatic, 80% of them by age 40. So very early on, and you see how steep, and the slope is not changing much over time. Patients are currently treated predominantly with beta blockers with a high recurrence rate, as you see here. Our data and the Japanese group data are pretty similar in showing a lot of recurrences, even with treatment of full dose of nadolol. And, part could be compliance, part could be really no response. Now there is flecainide as an additional therapy, but still we know that also with flecainide we have recurrences, not at this rate, but we may have. And furthermore, what we know is that the CPVT patients respond less well to the defibrillator, and some, definitely more than one group reported shocks, appropriate shocks that were ineffective in terminating the CPVT, that exceeds the success that is usually present in terminating other types of arrhythmias. So let's start from the recessive form of CPVT that I anticipated could be the low-hanging fruit, in the sense that we could just try to replace the missing protein. a little bit of architecture of the area of the heart and the structure that we are working on. This is a T-tubules, the invagination of the membrane of a cardiac myocytes. In the T-tubules, in this part, there are aligned the calcium channels. In front, at a 20 nanometer distance from the T-tubules, is the junctional SR. And the junctional SR is the home of the ryanodine receptor and the cardiac calsequestrin. So the physiology goes then when the action potential gets to the depolarized potential where the channels, the calcium channel can open, the calcium channel open, and a little bit of calcium, not much, meaning that this is not the calcium that activates contraction, is a signaling calcium, reaches the ryanodine receptor that is very regularly aligned to maximize the opening of the channel, this vestibula of the channel, to get as much calcium as possible to signal that it's time to release calcium from the junctional SR, so from this area of the SR. And these half moons in pink is calsequestrin. That is this protein composes a polymer, and the polymer is a buffer for calcium. This is the traditional concept. Calsequestrin is a buffering molecule. But now we know, thanks to the work of Wayne Chen and others, that, and Sandro Ghiorchi as well, that this protein is also working as a modulator of the function of the ryanodine receptor. So and is a stabilizer of the ryanodine receptor. So when we have a loss of calsequestrin, we are losing something that stabilizes the closing states of the ryanodine receptor, so predisposing to the opening. So this is the reason why calsequestrin causes the same thing that mutation in the ryanodine receptor that make the channel prone to opens in diastole are doing, because it's a stabilizer. So when we lower the calsequestrin, our cells become prone to develop arrhythmias. So here is a homemade cartoon that intend to show you, what happens. This is the T-tubules, red the calcium channel, these are the ryanodine, and this is the junctional SR. So calcium comes in through the calcium channel, triggers release from the SR. Then here is the SERCA, the protein that is missing in our failure that Roger Ajal was trying to increase in the CUPID2. So SERCA brings this back to allow this release and reuptake. And then here we start having too much calcium that is released when there is a mutation, and the calcium is not released only during systole, but is released also during diastole. So what happened is that this excess of calcium get extruded from the SR with a stoichiometry that one calcium with 2 positive charges goes out, and sodium with 3 positive charges is exchanged, and therefore generates a positive current that depolarizes the resting membrane potential. And if this is a strong amount of depolarization, it will trigger the beats. So all this story to explain to you the molecular mechanism of the arrhythmias in the CPVT. So now we think that if we would be able to stabilize the ryanodine receptor by putting back the calsequestrin that is missing in the recessive form, then we would be able to interrupt this circle. Similarly, for the dominant form, if we could silence the mutant channels that open during diastole inappropriately, we might be able to cure this disease. And here you see, when you record from the mice with CPVT, that you see exactly this kind of phenomena. So this hump is like this one, and these beats at the end of pacing, that the red arrows are the pacing, you see that these are triggered beats. So this is triggered activity. So here is the construct that I showed you before, and here, instead of DNA of your choice, we have the DNA that represents the sequence of the calsequestrin. This is Marco De Negri, who did a lot of work and made this project successful, publishing a couple of papers that were our first attempt to develop the gene therapy. Then you take the virus, you inject it in a human. Actually, we were injecting in mice at this stage. It will go in the nucleus and produce the protein to rescue the phenotype, hopefully. So I said that we had different readouts. So one, of course, the most important one would be to see if the mice stop having the bidirectional VT that they develop when we stimulate with catecholamine these mutant mice. But another interesting one is that there is a mysterious phenomena, mysterious because we don't really know how it happens. Now we are studying this and we are getting more sense of it, but premature to talk about that. When there is a mutation in the calsequestrin, the amount of calsequestrin is reduced, probably because this cannot assemble well and therefore is eliminated by the cells, in the cells, because it's just not a physiologic protein able to do the job. But then other proteins are also diminished, xanthine and triadine. So calsequestrin, xanthine, and triadine are the triad of protein that works and regulates the ryanodine receptor. So when I said the calsequestrin modulate the function of ryanodine receptor, is actually in partnership with these other two proteins. And their stoichiometry is always aligned. So if this one goes down, all the other go down. But also if I reduce triadine, all the protein will go down in the same way. So obviously, the objective now is to see that when we put back the calsequestrin, we will abolish the arrhythmia, clear, but we will also increase the calsequestrin and change this. And here you see that actually when we infected the mice, we were able to rescue calsequestrin that goes back to the level of wild type, but also xanthine and triadine. And here you see also at the Western blot level that we are able, if this is the normal level, when we put back calsequestrin, we go back to values that are close to the normal for the different proteins. Another aspect that is important for fixing all the problems created by the lack of calsequestrin is that when we have a mutant animals, instead of having spontaneous calcium waves that may occur rarely in the wild type, what we see is that we get a lot of sparks that do not really disorganize in becoming waves, but they can predispose to delayed after depolarizations and arrhythmias anyhow. So we see that when we put back the calsequestrin, we normalize the behavior, and these are two different experiments. So we are active not only at the level of the proteins level, but the consequences of the protein level in the calcium physiology. And here is what we really want to see, that when we inject this protein in our mice with bidirectional VTs after epinephrine, we do not see arrhythmias anymore if we put back the calsequestrin, so the CASC-R33Q homozygous are infected, as opposed to the calsequestrin homozygous not being infected and having the arrhythmias. And here you see the dramatic effect that is really, really powerful. So now, the question that is interesting is, since we have had all these scientists telling us, no, you cannot be funded because you need to have a uniform electricity, which makes sense, but now why is going to be effective? So actually, we started discussing this with the group of Jim Wise, who had for many years studied triggered activity at the fundamental level. And what they demonstrated in silico, very interesting experiments, is the fact that I show you these waves, this depolarization that are called delayed after depolarizations. But since the cells are all coupled, a delayed after depolarization by itself is unlikely to propagate because the negative resting potential of the adjacent cells will not allow the propagation of a positive current. It is so insignificant as compared to the driving force to staying stable of the neighboring cells. So what it really, really takes to propagate is that many cells are coupled to each other and they oscillate in synchrony, so that the delayed after depolarization develop in multiple cells at the same time. So here they show that in silico, if they have 79 cells that are coupled and oscillate in synchrony, is not enough to propagate this. But if you have 80 cells, is the threshold for the experiment that they were doing to propagate. So basically, this model, before we explored in our cells, was a demonstration that to block DADs, you just need to uncouple some of the cells that stop oscillating because they've been rescued in terms of the normal physiology. And then you still have some cell oscillating, but this will not propagate and therefore will not create arrhythmias in the tissue. So this, when the reviewer asked, explain us what is the mechanism, we gave this mechanism, and now this is considered the reason why maybe triggered activity is particularly susceptible to gene therapy. Interestingly, triggered activity mediated by DAD is also considered the prevailing mechanism for arrhythmogenesis in heart failure. And this creates a nice loop with the attempt of Roger, where maybe circa is not the right way to repristinate and prevent the arrhythmias in heart failure, or even worse, is not the right one to improve the contractile function. But in terms of everything going to an idea that probably targeting triggered activity is a good objective for gene therapy in cardiac arrhythmias is true. Now we are trying to study a new model that we have developed for seeing whether this holds true also in long QT syndrome, where the mechanism of arrhythmias is a bit more debated. So now if we have a favorable mechanism in CPVT for targeting it with gene therapy, how can we do with dominant CPVT with the RNA interferon that I mentioned to you? So this is the cartoon just to show you that what you can do is to identify this molecule that will be able to lead to degradation the mRNA that is the target. So in our case is to promote the degradation of the mRNA for the mutant ryanodine receptor that is present in the patient. So before going to our objectives, I just want to acknowledge the work of others who have attempted in other models also to do RNA interference for arrhythmias. This is interesting, I will be showing data from an IPS cardiac myocytes of long QT syndrome type 2 patients. Of course, it's not a study in vivo, it's in vitro, but very interesting to show the model. So what they did, a group first studied the ACT293, expressing a hERG mutation and showing the ability of leading to degradation of the mutant RNA and trying to reduce the effect on the abnormal current property that were present in the mutant hERG gene. And then in the induced pluripotent stem cells, where you can get a bit more hints of the phenotype, and in particular, you have an action potential that you can record. And if you get these cells from LQT2 patients like they did it in this work, you see prolongation and even development of an early after depolarization up here, plus a reduction of the trafficking of the IKR channel. So the channel is not there to activate a repolarizing current, and the potential start oscillating. And this is one of the hypotheses on the arrhythmogenic mechanism in long QT syndrome. So when they did the allele-specific silencing, they were able to reduce the transcript with the mutation, repristinate the trafficking of the protein, and shorten the action potential in ventricular cell, atrial cells, and pacemaker cells. So this was a good proof of concept that if you work hard to develop your RNA that is specific only for the mutant, you can have a phenotype at the level of the action potential. Christine Seidemann attempted this in vivo in a model of hypertrophic cardiomyopathy. This is the common mutation that is present in this prosarcomeric protein. And the key aspect is that with this relatively standard dose now for doing gene therapy in the mice, they were able to have the success of inhibiting this mutation, getting to the reduction of the mutant transcript, and have some changes that were very positive in the hypertrophic cardiomyopathy that was here, and then, decreased and almost normalized the size of the ventricle. The problem with these experiments is that, unfortunately, after 9 months, the mRNA molecule that they had produced that was silent in the mutant transcript stopped working. And this was something that has been anticipated as a problem for the use of RNA interference as a strategy for gene therapy. So when we started testing and developing our molecule, we were encouraged by in vitro data, a little bit discouraged by this short-term efficacy that was shown in this model, but also encouraged by the fact that they got a result in an entire heart. So when we started, and Rosanna in the lab was the person who spent 1 year in trying to identify this RNA that was able to be selective. So she made a big screening using a cassette with the exons of the ryanodine receptor that harbor the mutation of interest, that is this mutation. That was the first one that we identified when we discovered this gene. And so she tried to get something that selectively will block this one without interfering with the wild type. And these cassettes were tagged with different fluorescent proteins so that we could really see when one color was going down because we were silencing and not producing that protein anymore or not. So this is the experiments in neonatal mice infected. And to go to the bottom line, you know, and avoiding all the other factor that I've shown to you in terms of what we can get as other endpoints in these models, this also was very, very, very effective, as you see here, in reducing the mutant protein and therefore repristinating the resistance to exposure to isoprotein, and also the animals did not develop the bidirectional VT. So what we observed is that what happened was not totally silencing the mutant, but changing the ratio between the wild type and the mutant protein that is still there, but there is less. So why is this ratio so important? And I don't know if this would be equally important in other proteins that are not ion channels, but for an ion channel that is a tetrameric structure like the ryanodine receptor, this is actually something that is likely to be very important. So if you think of an heterozygous condition where you have normal and abnormal protein, your ion channels that are in the junctional SR will be a mixture of a binomial distribution of channels with 4 normal and channels with 4 abnormal subunits. So you have a mix, normal protein, bad protein, and it distributes with a binomial way. This is the theory for all the tetrameric ion channels. So you have few channels that are completely good and few that are completely bad. Then you have some that are a bit more, that are with 3 wild type and 1 sick, and the opposite, 3 sick and 1 wild type. And the majority are 50-50. If you change the amount of the protein and it's no longer the 50-50 that you normally have, what you see here, the bad stuff, that is the yellow and the purple, gets less than you have here. And the good one increases, as you see the blue that goes from here to here after the infection. So the more you're able to push the ratio between the mutant and the wild type in favor of the wild type, you have an amplification of the effect because you actually modify the number of healthy channels that you have in the membrane. And that, you know, is probably the reason why you don't need to zero the mutant protein, but is enough that you change the ratio to affect electrically in a favorable way the cocktail that is effective. So now CPVT has become, and I'm very happy about that, you know, the preferred model to study many different other gene therapy. So this is a study by Xander Verens, who took another approach. So you hear about gene editing, and gene editing is now the best therapy that everybody has been dreaming, because rather than using the indirect approaches that we have selected, express more one protein or decrease the expression of a protein, with the gene editing, the idea is that we could be able to remove by homologous recombination the mutant segment of the gene and put back a copy of the normal one that we are also co-injecting. The big problem is that the heart, being a tough stuff for tough people, that's why we are working on this, on the heart, cannot be amended using the gene editing, because for gene editing to work, you need cells that are in the replicating phase. The heart is terminally differentiated, so no way that we can use it. But So in fact, there are a lot of experiments saying we have developed a good therapy of gene editing for the heart, but unfortunately it's done in iPS cells that are replicating. So you could envision doing that in an embryo, but not in a neonate or adult individual. So what Zander has done, however, has been to use something that happens as a side effects of gene editing that you can use to your advantage. So what this results is that there is a random insertion, not totally random near the mutation of the cassette that you prepare. And this, instead of being an homologous recombination that take out a section and put a section back aligned so that the frame of the DNA does not change, this creates a frame shift, is a damage, and results in an allele silencing through creating a stop codon, basically, in the mutant protein and not in the wild type. So it's another way of doing what we have done that may be risky because you don't control 100% this, but conceptually is a very clean experiment that shows that no matter how you reduce the mutant allele, even with another strategy, you end up having the same result of protection of the heart from the arrhythmias, as you can see here, that they show results very similar to ours in terms of the effectiveness of reducing the mutant allele expression. Very, very recently, a couple of weeks ago, another gene therapy strategy for CPVT emerged. And I'm very happy about this because targeting calmodulin kinase 2, that is one of the phosphorylating enzymes that are phosphorylating the ryanodine receptor together with pKa. And if you follow this field, there has been like 15 years of fight on whether it's more important pKa or whether it's more important CAM kinase. So it's like a soccer game, whether you are from Milan or Inter soccer team. My soccer team is CAM kinase. So I think that CAM kinase is very, very important. I love CAM kinase. And with a fantastic Chinese fellow who worked with me for 8 years, we demonstrated that actually, if you use a CAM kinase inhibition with KN93, and we tried many other inhibitors, you're really, really able to abolish all these triggered arrhythmias and delayed after depolarization. You get only, these things that are so small that they do not trigger beats. And so we proposed in 2011 that targeting CAM kinase would be a good approach. And again, we got a lot of criticism that it's impossible to target CAM kinase because it's ubiquitous. But now CAM kinase is seen at the level of pharma, a lot of interest, and I'm aware at least 3 companies that are developing cardiac selective or brain selective CAM kinase inhibitors. So this might be at the pharmacological level a new trend, but someone got a very bright idea. That was to express an inhibitory peptide, and this is the paper that just came out, that is very fascinating, and overexpress the CAM kinase inhibitor by gene therapy. And what you see here is that they demonstrated that if you take a wild type and you give this peptide, nothing happened, no arrhythmias here and no arrhythmias after you inject this. But if you take the mice with the mutation and you express the peptide that inhibits CAM kinase, is very effective. So this is strong point that supports, the fact that, here is another evidence of the VT that develops before if you inject only GFP in the adenovirus, or if you inject the GFP tagged inhibitor peptide for CAM kinase. So whether the field will go in inhibiting CAM kinase with gene therapy or with molecules is unknown. Probably if molecules are very selective, it will be easier to test molecules. But definitely, this is another very important proof of concept. And now I just want to close with something that is at the same time fantastic and scary. And just to remind you the ethical issues that come with working in manipulation of cells and manipulation of human beings at the end when this will be translated to the clinic. So this is just the schematics for the gene editing, saying that yes, you can put back a normal sequence where you have a mutant sequence if the cells is replicating. So for many years, this issue of in non-replicating tissues, the brain, the heart, maybe this should be done in embryos has been said, but not done. And obviously, I think that the two concepts are important. First, manipulation of embryo is sensitive for obvious reason, but among the obvious reason of ethics of changing, the embryo is also that while if I infect an adult or a child, I'm changing something, but when the child has a baby, the baby will not receive the changed material. If you infect an embryo, this will go to all the cells and will be also in the reproductive cells, so will be transmitted to other generations. So potentially is a dramatic technology. And so the field has been discussing this forever. And one day we opened science and it's there. Someone has done it and someone has published it. And it has been absolutely shocking to the field that science decided to publish and that someone decided to do the experiment. Not the most friendly face, I would say. Poor guy, he came out very badly, and this picture has been going on around the world. I don't know if on purpose, because of the discomfort of these aspects. So there has been an enormous amount of discussion whether it was good to publish, and the argument of science was, we have the technology, someone was going to do it, it has been done, and we have to report this. But it also generated some positive reaction on the scientific community calling for a auto-imposed, so as scientists, we want to regulate and we want to limit the manipulation of the embryo. The thing that is very striking about this is that I would have thought someone will do it to cure a terrible disease, and there are so many terrible diseases in the world that I would like to think that if there is a muscular dystrophy that puts people in a wheelchair, or SMA, that is a disease, neurological disease that kills infants by the age of 6 months or so, I would understand the pressure for that. But actually, this in utero, that was not done in utero, but opens to the in utero gene therapy. This was done using embryo that were not used for in vitro fertilization. And after they did the gene therapy, that was it, they didn't put it in utero, but is actually opening to the next step, that is applying this since it was successful in utero. But look at what they did, they accepted this therapy to treat an hypertrophic cardiomyopathy, which I think, it's a breathtaking concept, because we know that hypertrophic cardiomyopathy as cardiologists is a severe disease, can lead to death, but is not a disease that would kill, beside very rare mutation or double mutation cases. So it would have not been my first pick to test this one. So we have also to think, that when we are thinking about gene therapy, even in my perception, is something that is far away. And then, the technology is going so fast that this is really coming. So in response to this paper, the community, the people more active in the gene therapy for dramatic diseases, has posed a moratoria that was published in Science after this was published, whereby for the next 5 years, there is a commitment of the scientific group to try to limit the experiments on embryos. But I think that it's very important that as scientists, we are all aware that this is happening, and as all the advancement in technology is up to us to make it a good thing or a bad thing. Unfortunately, we know that very often when technology is available, most of the people will use it for good, but someone may have bad thought and use it for bad uses that we can imagine and we can think. So where are we moving forward? Gene therapy has been proven safe in different fields and also in the heart, maybe even if we have only one trial. Our trial for the recessive calsequestrin has been approved by FDA, and I just need to get the courage to do it. And the money, by the way, but that is a detail. I'm more concerned about doing it in a patient, even if I have patients who really want to do it, but it's a tough choice. If they say, no, you cannot do it, you can say, complain and say, I would have done it, but but now it's up to us. So it's very difficult to think of what to do. And you know that the technology is much far advanced. It's running. Sorry, it was Nature, not Science. The technology is going really, really fast ahead of us and ahead of what we are ready emotionally and psychological to take. But it's good because eventually, you know, we will have a step that is maybe not so far away to think that we could eradicate these diseases from the planet. Because if you think about gene therapy in utero, it means eradicating these diseases. So this is a fantastic step, but we have to go slowly and carefully and keep ethical concern and ethical standard very high, and just not to say, well, we are used, now we can manipulate whatever we want. Thank you very much for your attention.
Thank you. Questions from the audience, Al?
Yeah, so recently in collaboration with Brian Annex and Nancy Carrasco, we developed a sodium iodide symporter on AEV9 to track gene therapy in skeletal muscle. And I'm wondering, and it sounds like in this setting, you really want to know about uniformity of transfection. And have you incorporated things like reporter probes, in particular imageable reporter probes, into your technology?
In vivo, no. Probably just for you know, the lack of real need to track the distribution in the mice, because the mice have a small heart, so things look pretty uniform, at least when you do RNA by sampling different biopsies. But definitely this could be a very important point now that we are moving to test the gene therapy in large mammals' heart. So it would be interesting to know more of what you have, because one problem is a GFP based.
No. So it's a sodium iodide symporter, which will take up to 80-99M, so you can do in vivo spec imaging.
Okay, that could be a good approach, because actually one of the problems is that the GFP, for example, in the pigs is very toxic and gives seizures to them when it goes also to the brain. That is part of where you get. So I might be interesting to talk to you at the end and learn more of what you have.
Yeah. So that was a lovely talk. Congratulations. Beautiful stuff. Along the same lines of the question regarding transfections, some of the challenges that we find with arrhythmias, as you mentioned, a lot of the issues that we find with arrhythmias is that they're not necessarily just related to ion channels, and sometimes they're not even related to the myocyte, but it has to do with fibrosis and the interaction between myocytes and fibroblasts. And I was wondering, when you consider this, are there ways that you could modulate the communication, the myofibroblast communication, in order to deal with the vast majority of the arrhythmias that we actually encounter?
The reason why I'm starting from the channelopathies is that these are conditions in which, from what we know from patient study, MRI study in the patients, and so they don't have fibrosis associated. So they have a normal heart, and it's really a pure electrical abnormality. I think that already the step of the hypertrophic cardiomyopathy may be different, okay, in embryo, because then you prevent from the beginning. But once the disease has developed the fibrosis, I think that it would be very, very difficult to simply modify a protein and revert what has already occurred. So I wonder the people who are working in the like the Seidman in the gene therapy for the cardiomyopathies, you know, how they think to address that, whether they are thinking of neonatal diagnosis and treatment at that stage, because, you know, a few years, 10 years of age, 15 years of age may already start having this. And, the problem that we have with the gene therapy is that from how we see it now, if you have to do one shot meaning one protein, one target, it's okay. But if you need to say, okay, I change the mutant, but then I also give something else that is another gene therapy for preventing the fibrosis, then it becomes something that probably has more contraindication than the drugs.
Wonderful talk. So in my understanding, AAV is episomal, although it can stay in the cells for like a couple months, but it's not life-lasting construct. So gene editing, another way, maybe it's a better way, because it creates a permanent change in chromosome. So But so my first question is, so how do you address the transient effect of AFV? The second question is, even for the gene editing that creates stop codon, that will create haploinsufficiency, whether CVPT patient with haploinsufficiency may still have disease.
Okay, so all good points. So first of all, I think that the episomal problem is not a point of 4 months, because there are now human data that show that patients infected for gene therapy still have an active episomal localization that is still producing the protein after 8 years. This is the highest that has been reported. And I would feel very comfortable if my patients would have no side effects and an episomal that lasts even 5 years, because the real problem is if you have a 6 month and you have to redo, you still have high level antibodies, and that would be really a problem, you know, because when you do the gene therapy, you elicit with the high dose that you have to give, you know, an antibody response. So you cannot do another therapy after 5 months. But if you have something that is affected for 5 years, I think that this would be absolutely enough. The gene editing, I'm a bit cautious with the CRISPR-Cas9 because CRISPR-Cas9 has a lot of off-target effects. And so it might be beautiful, but you know, the minute that the construct goes, we've been just a step back. So we've been very careful in the field of gene therapy to try to avoid the viruses that insert the construct that you produce in regions of the chromosomes, because you are never sure that it's only the safe harbor that you are targeting. It may be somewhere else. It may be in an encoding region that down the line will be cancer-inducing or things like that. So the school of thought that tries to avoid the insertion is also a bit skeptical of the effect of the CRISPR-Cas9 homologous recombination, because, you know, it may act as a non-homologous recombination somewhere else and start creating stops of protein or just, you know, insertion of abnormal sequences in there. Beside in the heart is not an issue, because you can really not get, we have tried so much. We started with all the possible technologies, you know, from the zinc fingers 10 years ago, all the way to TALEN and now CRISPR-Cas9, and we don't get more than 2% of the green fluorescent that suggested there has been an homologous recombination. So I agree with you that using it for non-homologous recombination can be very risky, because if there is an off-target effect, you can truncate other proteins. So, yeah. So I still think that an episomal is a safe approach.
So Silvia, that's pioneering work, and thank you again for 2 wonderful lectures these last 2 days. So your antigen receptor RNAi experiments, that was done in a viral construct, is that right? So I just wanted to ask you, not that this is necessarily better, but as you know, I'm sure there are clinical trials with mirrors and antimirrors of just naked RNA delivered, and at least in some advanced diseases, it looks favorable at this point. So I wondered if you could just comment on, with the RNAi approach or a mirror antimirror approach, whether that could perhaps even be simpler, just naked RNA delivery.
Yeah, the problem that naked RNA delivery, it doesn't last for a long time. So you don't get to the point that you have a permanent cure and a permanent solution. The other point in that, in our hand, neither naked delivery, nucleic acid deliver, nor the plasmid delivery, and even the exosome delivery has been successful. And I don't know anyone that has been successful in the heart to get that. And I have no idea on how long that would remain. But clearly we need to get out of the virus. You know, it's like the ablation. We keep burning and saying it cannot be the final destination, is a period. And maybe the periods last many years, you know, in science. But I am sure that we cannot continue with the viruses. So there should be other way of synthetic virus-like structure that can target. Yeah, or chemically modified. Yeah. Yeah.
Did you have a last question?
I'm sure you've thought a lot as you stand and think about making this big step to the calcium study. What is the population you're thinking of launching? Is this patients with refractory disease where they've been treated and failed? Is it,
Yeah.
where do you think in this field in general, where should the first steps be made?
Yeah, I think that the recessive CPVT is a disease that is very, very rare. Being very, very rare, we know it means that it's very, very lethal. And these patients, if they miss a couple of doses, they are really at high risk of sudden death, more than the ryanodine receptor patient that we already consider patients at high risk. A large trial would not be possible. This trial is anticipated with 9 patients as a pilot study. I think that there are patients in this population that are good candidates for this because they don't respond to any therapy. I have a 25-year-old woman who has had a lot of shocks and a lot of events, and she is really calling us every 6 months and saying, is the trial starting? Is the trial starting? Because she just cannot live knowing that sooner or later she will have another one. So there are patients that can be good candidates for that. Another group of patients are patients where the compliance is not good. For example, there is a cluster of these patients in Israel from a Bedouin family where they actually discovered the gene that keep marrying within the family, keep not treating the children. And so, maybe conditions that are extreme, but still, these people cannot follow a medical practice. So I'm in contact with Leo Gepstein, who, besides being a scientist, who is also doing gene therapy, is heading the cardiology where these patients are followed, sort of say. So maybe, some of these people with extreme conditions might be persons who may benefit of such a therapy. For me, is really important to have a proof of concept where we have good rationale for seeing efficacy, and also to test, how much we should give to this patient and so on. So just because I'm also thinking that this is a optimization of a therapy that we still do not know how to handle, I've not started yet. So I think that I would like to see that this therapy is going uniformly to a big heart, and so to do some mice experiments. But consider that I'm struggling now because finally my studies are funded by a European grant that has as a mission to fund high-risk research. So we are in the high risk. So despite they gave us a lot of money, producing the virus that is needed for one injection in the pig is more than 100,000 euros. So it's not that you can really play a lot with these and say, today I test this one, tomorrow I test this other one. And so I think that maybe an optimization or a possibility of assessing the distribution could be very helpful.
Thank you. Thanks so much for a great lecture.